All right, we're going to get started here. Thanks for joining us. I know there's a few that will be coming on a little bit later, and I look forward to sending this out to folks as well for them to see. My name is Janice Onenson. I'm the Director of Academic Initiatives at the Minnesota State IT Center of Excellence. And with everything that's happening in the world, there's a few things that we've done at the Center of Excellence to help bring the information that usually we would do through training classes or online face-to-face, all sorts of options, but we're trying to do something a little bit unique and bring people together to still learn. So we're here today, and we'll be here every other Thursday at this time to present a topic or so. So today we have Josh Morgan, who is from SAS, and I put everybody in the chat. So he's a guest speaker from SAS. He's also SAS National Director of Behavioral Health and Whole Person Care. If everyone was registered online, you can see his complete bio. But today he's going to talk data for good. There's a lot of things that are happening in the world that we need to figure out, and he's going to start that today. So I am recording this call and we'll have it available, but Josh, I'm going to let you go forward.
Fantastic. And is my screen still sharing for the slides?
Yep, I still see it.
Okay, wonderful. It wasn't showing me it on my end. So happy Thursday, everyone. I hope you all are doing well. I am based out in sometimes sunny Southern California. It's a bit overcast today, and we'll be having some more rain, I think, coming up this weekend, which is a little hard when we're all cooped up inside. I was sharing with Janice beforehand. Working from home normally, these circumstances have not impacted me as much of my outside of my normal routine, except not traveling, but lots of rain in Southern California does throw things, not getting us to be able to go outside as much. Thanks so much for having me and joining this conversation today. As Janice said, we're gonna talk about these ideas of how data can be used, hopefully for good, giving us a more complete story. And I think that that's really important, especially right now in the midst of a crisis, of a pandemic. You know, data, we're hearing lots of people talk about data. And for many folks, this is what it feels like looking at data. Even those of us who may be data people may look at this and go, I don't know what to make of anything. And especially in my world, in healthcare, and then especially in behavioral health. I'm a licensed psychologist. I was trained predominantly to do clinical work. That's where my passion was. I wanted to help people, ultimately. I wasn't interested in teaching or research or analytics or administration. And now I'm working for an analytics company. It's a little ironic in some ways. And yet, I think it hopefully helps give me a different level of hopefully good skepticism of where data can serve us well and where there's challenges. I kind of had this same view, even though I liked my math and stats and chemistry courses a lot. But for many people, the challenges as a barrier to data that I frequently hear is, one, data doesn't always demonstrate our impact, especially in things like behavioral health and in broader healthcare. We often don't get credit for the good work that we are actually doing. Even in my own work, when I was running a adolescent self-injury program as an intensive outpatient level of care, I was asked to end up comparing different of our outcome measures of different IOP programs. And our general adolescent IOP program on this looked like they weren't doing anything. They weren't having progress, when in fact, based on at least anecdotes, we were seeing significant progress. My program looked like it was making huge progress, but we were focused on, again, self-injury, suicide reduction, and those were the things being measured. So I think sometimes we don't get our impact demonstrated and get credit for what we're doing because we don't always measure the right things. I hear a lot of people also complain about data not being actionable. How can I use this, or I can't use this, it's not really helpful. We'll get into a few ways that I think data can be actionable in perhaps some more creative ways. And then another big challenge is that in highly unfunded or underfunded areas anyway, and behavioral health, public behavioral health, I haven't heard anybody ever say that behavioral health is overfunded. If you do, let's talk. If we have to add data, research, analytics, evaluation on top of things that we're already doing, that's very real money that in theory could actually take away from already underfunded resources. So what do we do about that? Some of the things that I found is, as I mentioned for this first one, about not getting credit for what we do, is I think a lot of times we measure things wrong, and we measure the wrong things sometimes. I'll get into more details about this in a little bit, but we also don't know how to use the data. Oftentimes, many of us, especially end users like me, who may be a psychologist, maybe a clinician, perhaps administrators, policymakers, may know in principle that we want data, that we want to have data-informed decision-making, but we don't actually know what that means. We may not have actually been trained in how to do that kind of work. And then we tell incomplete stories quite frequently and limited evidence. That has a lot of potential significantly negative impacts that we'll get into. So some of the things that I would assert and say that we need to do is, one, data needs to be more holistic, which also means strengths-based, not just looking at the reduction of negative things, but what are the good things going on. In the middle of our COVID crisis, we're hearing a lot of data focused on surge capacity, lives of people who are infected, number of people who are dying, very important things. Then we hear anecdotes about people helping one another, creative ways economies are able to keep going, businesses are being nimble, people are now working from home, schools are being able to enhance creative ways of being able to educate. Are we capturing that story? That's a really important one, and I think right now, of all times, this is very critical. The other piece is the absence of strengths oftentimes can be a risk factor, and improving strengths, things like social support, and with our social distancing, or as I prefer and many people like talking about it, more physical distancing, because we can have social connections like we're doing now, social support is absolutely critical across healthcare. In behavioral health, social support is one of the best predictors of suicide and one of the best protective factors against suicide. But how often do clinicians get credit for building more social support? I think that's something we really need to consider. At a system level, and I think right now again too, where you're seeing the power of data at more population and system levels than maybe at an individual level, and seeing how that really can make an actionable difference. That's an important thing that many folks, especially in my camp, in the clinician realm, we're trained to think of, what do I need to do for Josh Morgan today? If I'm looking at a whole group of people, I don't know how to use that data. Again, kind of going back to not always being trained in this type of model. And then with all of these pieces, whole person, holistic data can be a very powerful advocacy tool. What kinds of systems, structures, benefits packages, policies maybe could be different because of the type of data that we're looking at? So asking questions like, what is it that we often measure? What are the intended and unintended consequences? What are we missing by the data that we are looking at and reporting on? Because what we measure matters. What we measure ends up, in my healthcare language, becoming the focus of treatment. It becomes our treatment plans because that's what we get paid on. And treatment plans end up becoming the interventions. And if the only thing we end up measuring, for instance, is reduction in hospitalizations, all of our interventions get focused on reducing hospitalizations. Think about COVID. What are we measuring? What are the intended and unintended consequences? What are we missing? If we only measure death, for instance, what other things are we missing? If we only measure people who are infected, what are we missing? What we measure matters. And I think we can broaden things out and be even more holistic. Looking at unintended consequences, go my world again, behavioral health quite specifically. I think data can often frame things very negatively. Several years ago in California, we had Senate Bill 82 enacted. This is known as the Mental Wellness Act. I want to emphasize the wellness part of it. This is in the title of the bill. Let's look at some of the language. We have 1/5 of people visit a hospital emergency room at least once a year, and we have unnecessary inpatient hospitalizations, inappropriate, unnecessary utilization. Law enforcement personnel have to sit in the EDs until placements are found. Very negative things. Move on to something unique to California, our Mental Health Services Act, also known as Prop 63. It's been around a little over a decade now. For those not familiar, it is a 1% tax on people with a personal income of $1 million or more to help fund that gap in mental health services. Again, nobody's ever said mental health is overfunded. We always need more. And we're starting to pay attention to that, often because of data. One of the key principles in MHSA is these principles of recovery, wellness, and resilience. Really actually positive strengths-based things. But again, let's look at how the data is framed. Untreated mental illness, leading cause of disability and suicide. We have the imposition of high costs. Children untreated become unable to learn. Adults lose their ability to work, become homeless, frequent hospitalizations, jails, state, county governments forced to pay billions of dollars. Not good things, any of this, for SB 82 or MHSA. To be fair, if we're talking about spending taxpayer money, we usually have to frame things in a negative to say we want to spend more money. But what are the consequences? If these are the problems that we are presenting, and they're all in the negative, the outcomes then that we're asked to measure end up becoming negative as well. Again, let's look at the Mental Wellness Act. The outcomes explicitly stated were reduce unnecessary hospitalizations and reduce recidivism, namely criminal justice recidivism, and mitigate unnecessary expenditures of local law enforcement. I don't think any of us would say these are bad outcomes by any means, but does any of this represent mental wellness? What about MHSA? Again, focused on recovery, wellness, resilience, and yet we have explicitly said the negative outcomes, and it's reducing negative outcomes. Again, you look at this list. I mean, I don't know anybody who would say we don't want these things reduced. But what happens when this is the only thing that we're talking about? They're important. They don't tell the whole story. And while it may be hard to measure things like recovery, wellness, resilience, etc., they're not. We say that these are critical principles, but they're not required to be reported on. We don't end up reporting on it because it's not required. And in behavioral health, there's a lot of stigma and discrimination in general. We need to start changing perceptions. This is what we often think about when people talk about behavioral health. And we need to change the perceptions from this into this. It's everybody. What happens when the only things we end up talking about, because the only data we're reporting on, is reducing hospitalizations, reducing criminal justice recidivism, reducing homelessness, for instance? What ends up being applied is the people with behavioral health conditions are filling up our hospitals, filling up our streets, filling up our jails. The reality is it's actually not true when you dig into the data there. There may be a higher percentage than the general population, but that doesn't help combat stigma and discrimination. While we need to look at those kinds of outcomes, there's other outcomes that may be able to actually help us decrease stigma, decrease discrimination by adding a more complete story to what's going on and recognize that these are people. These are our neighbors, our loved ones, our family members, us. If we look at SAMHSA, if you're not familiar, it's the Substance Abuse and Mental Health Services Administration, a federal agency under Health and Human Services. For years, actually, they've had these 8 dimensions of wellness. How often in behavioral health, in healthcare in general, in education, in other parts of life, do we measure more than really usually one of these dimensions? What happens if we actually were to start reporting on environmental outcomes for people with behavioral health, spiritual outcomes, social outcomes, again, social support? What about volunteerism? People with serious mental illness may be forever on disability, and they may need to, but could they contribute to a community garden? Would that not make their lives better and perhaps the lives of the community? If we don't measure that, if we don't ask that as an actual outcome, it doesn't become a priority in treatment. Funding doesn't happen. For many of us, under the best of circumstances, trying to seek help in healthcare often looks like this. I can't see any of you right now, but most of the time when I ask this, put this kind of slide up in an environment, everybody raises their hand, basically saying, yeah, that's what it feels like. I have a doctorate. I have a license. I've worked in a hospital system. I've worked in county government. I now work in a private bureaucracy. I know bureaucracy. It feels like this, trying to get help. A lot of my world, and I previously had worked for the San Bernardino County Department of Behavioral Health. I was their Chief of Behavioral Health Informatics, overseeing research and evaluation, and provided some coverage as the Interim Deputy Director of Program Support Services. We served the public sector folks, people on Medicaid or without insurance predominantly. In my current role in SAS, I usually work with public agencies, so also dealing with the folks being served by safety net populations, people at high need. Again, those of us who have resources, who have knowledge, this is what it feels like, getting help. Now imagine a lot of the people who need help, and we can put this in the midst of the COVID crisis again right now. How many people know where to turn, what to get? Even the best of circumstances, we don't always know. But imagine people living with one or more behavioral health conditions, add on top one or more physical health conditions. And again, in the midst of COVID, we know chronic conditions are some of the best predictors of very poor outcomes and death. Add on top of this potential poverty and or homelessness and or incarceration. How do we expect people to navigate our systems? Oftentimes our data is still focused on the individual, on what they could be doing differently. And that may be fair. But what if it's our system could do things differently? Can data be used for good to help enhance a more holistic story and actually advocate for system change? In broader policy conversations, there's more and more talk about these ideas of integrated health, whole person care, lots of different terms around it, but this idea of can we live longer, recognizing chronic conditions being comorbid lead to higher death rates, lower length of life. As we've seen, life expectancy in the United States has been dropping for several years, often tied to suicides and the opioid epidemic, with a slight bump, I think, recently. These things are significant. Behavioral health can be fatal. Some of you may or may not have seen this statistic that people with SMI, severe mental illness, can die up to 28 and a half years earlier than the general population. That's a long time. Sometimes it's because of direct things like suicide, like overdoses, etc. Oftentimes it's because of other comorbid conditions like heart failure, diabetes, etc. When I was with the county, one of the things my department did and I had to report on annually was what we called a penetration rate, a data element. Looks at what percentage of the Medicaid beneficiaries in our county are actually being served by our Department of Behavioral Health as a way of looking at kind of access to care, are we providing appropriate resources, etc. You look at that at a general number countywide, but also broken out by a variety of demographics, one of which was age groups. We actually had a decent penetration rate across age groups, and we had specialty older adult programs, both for outreach engagement as well as treatment. But when we looked at that penetration rate, when you got that older adult category, it dropped significantly. At first, my team and I were looking at going, what is going on here? We have these great programs. We have specialty programs. Why is the penetration rate dropping? And I remembered this statistic. They're dead. Those are real lives. So what do I mean by whole person care? In healthcare, in government, there is no end to number of initiatives, funding streams, etc. This is just a small sampling, I would say, of some of the dominant programs that we call things that really ultimately go into this definition of whole person care that I like using, of caring for people in an individual, person-centered, strengths-based way that includes things, behavioral health, physical health, social determinants, criminal justice, housing, etc., all ultimately for the goal of the right care in the right place at the right time at the right price. This may sound like the triple aim if you're familiar with it, and indeed it does. We just want to serve people better. We want to improve our communities. And data can help us do that by getting a more complete picture across all of these types of streams. Some of the things that I personally advocate for is that we need to broaden out the definition of health. It needs to not just be about reduction in pathology, as I've kind of been talking about there. It needs to also be about the increases in strengths. It needs to be non-health outcomes a lot of times. Treatment compliance, that's been a term that has been used historically. Just changing that into adherence emphasizes more person-centered language. You have a role in your treatment. You have a voice. Something that I am seeing, thankfully, more and more often. And then this idea of value, return on investment. In the midst of the COVID pandemic, we are again returning to these ideas of value. We are tanking the economy in many ways by doing physical distancing. Is that valuable? Is it worth it if we save lives? If we go from a projection of 2 million dead to 200,000 dead, is that worth it? Even if you save one life, what is one life worth? If you go back to the statistic I was sharing about people with serious mental illness dying 28 and a half years earlier, what if we were able to reduce that and say it was 15 years earlier instead? Is that valuable? We may be spending more money, but it's a different type of return on investment. What is the value of life? If we don't evaluate data, if we don't capture data in some of these ways, we won't be able to ask these questions, and that has very direct, very real policy implications that affects lives on a day-to-day basis. And again, we're seeing that in play every day in our political world about whether or not how we respond to the novel coronavirus and what are the best ways to handle that. And again, we may spend more money in certain areas, but even talks about spending more money in housing, saving money in a hospital setting perhaps, or partnering with criminal justice. In San Bernardino, our probation department gave us behavioral health money because they recognized that spending more money in one area would save money holistically. If we're only evaluating that return on investment and value in a silo, we're actually continuing to contribute to this siloed thinking, and I would argue in general. Getting back to this idea of actionability, usability, data should be able to help us make decisions. It should be useful. And again, there's this question of what does it mean? And here's a couple of screenshots. These aren't the interactive ones that are a lot more fun, I have to say, but to put them in slide decks, y'all know you got to get a screenshot here. But I want to kind of talk us through a couple of ways of what we can think of for actionability on making differences in people's lives. This is representing results if we were to do kind of customized risk stratification across a population. In this narrative, I like thinking about if we were to look at people who are at high risk of some of these predominant negative outcomes, since that is a driver: reduced emergency department utilization, homelessness, criminal justice recidivism. And if you can identify that type of risk by bringing data sources together to get a more whole person story, you can risk stratify that. In this case, we have an example of that top 5% in risk, which we often will talk about. And at the bottom are what can be traditionally thought of as counts, but on the foundation of truly advanced analytics of bringing data together and doing that risk stratification. If we're able to more accurately be able to assess in our top 5%, what percent of people have criminal justice encounters in history, homelessness, serious mental illness, addiction, history of trauma, veteran status, etc. Is that actionable at a system level? I would make the case that yes, absolutely, because now we know what kinds of programs we need to fund, what kind of programs we need to institute. If we talk about health plans, what benefits packages do we need to put into place? In California, we now have a Surgeon General, big emphasis on ACEs. If you're not familiar with that, adverse childhood events, kind of ties into this idea of history of trauma. When we have more data emphasizing the importance of trauma in our lives and the impact of it long-term on outcomes, we can start instituting funding. Because of data demonstrating the power of ACEs, in California, we are now, at least in Medicaid, actually funding for trauma screenings because of that. Very direct way at what I call a system level of actionability, saying we need to put new kind of programs and policies into place, including funding. At another level, and I don't have this in the example here because of the screenshot variety, but if you really want that individual level actionability, and some of these you can actually, depending on how you build types of data, you could, in my case, actually double click into it and get a list of people. So perhaps before they're released from county jail, state prison, etc., if we know that they're high risk for recidivism or needing health care, while they're a captive audience, getting them screened for Medicaid or other health coverage, getting them set up for outpatient appointments to be able to help prevent issues afterwards, that gives you that individual level actionability. And again, getting that more holistic story empowers healthier communities by being able to allow for a more complete picture as to what the needs are. As another kind of way of building potentially compassion, anybody working in data and healthcare may be familiar with some of these metrics, the 7-day follow-up to hospitalization. It's this idea of if you get hospitalized, we want you in many cases to have an outpatient follow-up visit within 7 days of discharge. Kind of makes sense in most cases. And then 30-day readmission rate, how many people are readmitted to the hospital, potentially for any reason, but often for the same reason. We don't want that happening. Just being able to identify who did not follow up to hospitalization and who were readmitted within 30 days, that's a group ripe for outreach and engagement, which is something we're doing more and more of across the country, thankfully. But what difference does this make? Because a lot of times people who don't follow up and are readmitted are also often the people we label as the quote unquote resistant, non-compliant to treatment. Are they really resistant and non-compliant to treatment? This is where, again, whole person data can tell a more complete story and tell us what's going on. In San Bernardino County, we had an outreach and engagement program funded under the Mental Health Services Act with innovation dollars. And the assumption was that these folks are just simply that, resistant, non-compliant to treatment. They didn't show up in our system. And by looking at the data, we actually found that wasn't true. We had evidence that people were trying to seek services over and over again, but they stopped at the assessment level or a crisis visit. That's an indication to me that these people do want help, but there's something about the system creating a barrier. This is also where then anecdotal information can pair up with it to give more insight as to how do we make sense of this data. Even in this example of a screenshot, we talk about transportation. San Bernardino County, keep bringing that up as my lived example, is actually geographically the largest county in the United States, over 20,000 square miles. We have very urban areas, very rural areas, about 2.2 million residents, and about 700,000 Medicaid beneficiaries, so not small. As the Department of Behavioral Health, we had to serve the very rural to frontier areas as well as the urban areas. Transportation is a barrier. If you have data to demonstrate maybe transportation is the challenge, that's the reason somebody didn't follow up and were therefore readmitted. Having worked in a hospital and seen people come in over and over again, it's very easy to be like, really, you're back? Come on. But if we had one more data element saying they can't get there, there's a transportation issue, could that actually build a little bit more compassion and empathy, even at an individual provider level? Maybe perhaps having us drop those labels of resistant, non-compliant to treatment. What would happen at a policy level? Can we build more compassion and empathy there? And that's what we're starting to see. Now, many states' Medicaid plans cover transportation benefits because we recognize if you can't get to the appointment, nothing's gonna happen. We're starting to do outreach and engagement and recognize the importance of person-centered care because that actually impacts those negative outcomes. But if we don't measure the positive side, the strengths-based pieces, other creative things, we just won't know. And I keep thinking back in the midst of COVID, when you talk about risk and who is at risk for complications, do we combine data? Do we get a holistic view of what people's needs are to be able to know who is at high risk, either of complications from COVID directly or other social complications? There's lots of talk about domestic violence, child abuse, elder abuse, dependent adult abuse, etc., that will go missed. Maybe having whole person analytics can help all of us be able to support people more proactively before it becomes a problem, and set people up with virtual social support. Technology can benefit us in many ways. The other things to consider is if we cannot tell our story and can't tell it holistically and don't get credit for what we're doing, funding goes away. Mental Health Services Act in California has been under fire for several years because we are not doing a very good job of telling a statewide story of the impact of services. We're talking a couple $2 billion a year in funding. That's a lot of money. You want to be able to demonstrate, does it work or not? There have been efforts to, and some have succeeded in actually taking some of the MHSA money and diverting it other places. If we were able to tell the story that it was effective, those diversions wouldn't have happened. What about other healthcare in general? Health plans, benefits packages, etc. Even in non-health, homelessness. Historically, for decades, we have not done a good job of telling the story of serving the homeless. Now we are, often because of data, but having data to demonstrate that impacts of funding make a difference in people's lives really can be hugely beneficial. And again, very much I advocate for not just looking at the reduction of the negative outcomes, but increasing the positive. Also, effective programs could be changed. If we know something works, but we cannot demonstrate that, it's going to go away. I really saw that running a clinical program. My adolescent self-injury intensive outpatient program was grant funded originally. And that's where I really saw initially the power of data as an advocacy tool to be able to say, this program needs to continue, please continue our grant funding. Or advocating to the health plans who don't normally cover this type of program because it doesn't fall under their normal definitions of things. Look, I have data to be able to say, it makes a difference, you should fund it. That changes lives. In healthcare, in analytics, the goal of everything should be to be curious. It's one of the things I have fun in SAS is that's our mantra as well, as to be curious, but it fits my training very well. If we are going to answer questions, to be able to serve the community, to improve healthier lives, to combat pandemics, we need to be curious. Have we been appropriately curious on all of these fronts? Have we asked enough questions and gotten enough of a holistic story to do due diligence? I mentioned before about anecdotes. A lot of times they get poo-pooed for lack of an academic term. I really believe data is not the end of the story. It's the beginning of the story. It starts a conversation. My dissertation was qualitative, so I have a fond place for narrative, but I also know firsthand where clinicians in particular, and I've done it too, this one person's life was changed. And it can be true and it can be wonderful. And those can be heartwarming stories that are very useful, including for advocacy. But what about the 100 other people we served? Did they make a difference? That's where the quantitative and the qualitative can come together to really tell, again, a more holistic story. Help us recognize that these numbers are lives. That's when we can use data for good. Being able to have initial results like we did in this outreach and engagement program I referenced, staff can help us understand, what does this really mean? When people just keep having assessments and crisis visits, but no routine outpatient visits, why is that? Well, as they've gone out on those visits with people now and seen firsthand, light bulbs start going on and realize, oh, maybe we need to do things differently as our system. They can bring life to things. Data can be used for good to improve our systems. I also would make the case that data brings us together. If we have to share data across systems, health and non-health, that means we actually have to talk. Are we interpreting things the right way? Are our goals in the same place? And when we start looking at data in this kind of way, we may recognize that we're not in competition with one another. Sometimes counties with each other, with the state, etc., states with each other, with the feds, can feel like in competition. Especially in the public sector, we are all in on the same goal. We want to make our communities better. Let's act like we're in alignment, that we have the same goals in mind. And again, hopefully data can humanize us. It's not them, it's us. So in summary, I would again emphasize that data can be used for good and can change lives when we are more holistic, doing more whole person, which includes being strengths-based. It can be usable on system and individual levels. That policy advocacy piece is one that I would really emphasize and try to remind people of. It's become really more of my passion area, moving out of clinical work and into this world. I see myself really in the role of an advocate. How do I use data to tell a better story to make sure that people are served and that lives are changed? I hope it still aligns with my reason for becoming a psychologist in the first place, is I want to help people. It's a different way. And we can do that by building more compassion, by combating stigma and discrimination, and by collaborating more. So my encouragement to all of you is don't settle for a slice of the data pie. We need to keep advocating for the whole data pie because it'll better represent the whole person and our whole communities and help us better serve when things are good and when we're in the midst of a crisis like we are now. If we were able to have a whole data pie, what different responses could we have? Here's some of my contact information before we open up for questions, comments, etc.